Hello there, everyone. Welcome back to Dementia Care Source. For this episode, we're going to be going over a few of the different nursing professionals you may encounter, delirium versus dementia, code status, meaning full code, DNR, and medications related to dementia. And our special guest tonight is Kayla Steele. She is a nurse practitioner in rural Kentucky. And just a quick disclaimer, all the content we're going over has been created for informational purposes only. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare professional with any questions that you might have regarding your medical care, and never disregard any professional medical advice or delay in seeking it because of something that we have gone over. So seek your primary care provider first. And with that, I'm going to hand it over to Kayla Steele to talk about the nursing medical roles you may encounter.
I know that that's one thing that can be confusing for families who have loved ones in hospitals or nursing homes or going back and forth between the two. There's a lot of people coming in and out and not always knowing who to ask for what kind of help. So CNAs or nursing assistants are employees who have basic training, no sort of it's not a college degree requirement, but they can help with toileting, bathing, transfers, and feeding. They take vital signs, so blood pressure, temperature, that good stuff, and they usually work in hospitals or nursing homes. The CNAs in nursing homes can take an additional class in order to be able to give medications. So if you do see a CNA giving medications in a nursing home, that doesn't mean that it's illegal. That just means they've had a little extra training. MAs or medical assistants you'll usually see in doctors' offices. They do everything that a CNA can, plus they can do like injections and EKGs. LPNs are nurses. They have a 1 to 2 year program, and they usually work in nursing homes and doctors' offices. Rarely will you see them in the hospital, but they can do most medications, and they can do IVs, they can do injections, they can do assessments on patients and document and chart like a nurse. You won't usually see LPNs if they are in the hospital in the ICU because they're not allowed to do some of the different, like more advanced IVs, like lines that go into central veins, or ventilators. They're not trained on a lot of the medications that patients require if they're ventilated and sedated. RNs, they can have either an associate's degree or a bachelor's degree, so a 2 or 4 year program. You'll see them usually in hospitals, and then one will be, you may have one at the nursing home who's kind of responsible for documenting everything and doing kind of a case management role, but rarely will they be involved in patient care in a nursing home. That's usually LPNs. So they can do everything that the LPNs can, and then also central lines, more advanced medication management and that kind of thing. APRNs, also called nurse practitioners, they are RNs plus 3 to 5 years of grad school. They can specialize in a few different areas. Family nurse practitioners can take care of anyone in the primary care setting from birth to death. And then acute care nurse practitioners are the ones you'll see in the hospital. So they'll be like hospitalists in the ER. They can admit patients to the hospital, round on them, work on different like cardiology teams in the hospital, that kind of a thing. But you won't find them at like doctors' offices. They can usually, it's their scope of practice is dictated by state laws. And so in some states they can practice alone, in some states they have to practice under a physician. And then which medications they can prescribe is also governed by the state just legislation and the Board of Nursing and the Board of Physicians. So that depends state to state, but usually they can take care of most patients in like a primary care setting. Sometimes, depending on laws and physician preferences, nurse practitioners who are like in the primary care family setting can also round in hospitals on patients. or in nursing homes. So you'll see a family practice in the nursing home or hospital sometimes as well. And then your family practice physician, that's who a nurse practitioner would be working under, and they have like full prescriptive authority.
And by that you mean?
They can prescribe anything that is legal to have.
Yeah, they, like you said, they do it all. Yeah. Do you care to talk briefly about kind of, I know how you have worked your way up through a lot of this, kind of how you started as early
Yeah,
on?
so I started as a CNA in a nursing home while I was in nursing school. Went ahead and got my bachelor's of nursing and worked at on a telemetry floor at a larger hospital for a year, and then went to a med surg floor where I worked at rural critical access hospital for a couple of years on med surg, and we had a lot of elderly patients and a lot of patients with dementia. And of course, those always have a special place in my heart. And now I'm in the urgent care setting.
Very neat. Okay, so that is looking at the diversity. You know, I feel like even as a speech therapist, I walk into the room and they say, "Oh, are you a nurse?" And they say, "Oh, we need a nurse," and I have to say, "Okay, which one?" Because there's such a wide variety of nurses that they see throughout the day. Of course, normally I'm working mostly in the hospitals now. They mean the RN,
Mm-hmm.
but yeah, it's just a wide array to get to
Mm-hmm.
work with. So our next topic is delirium versus dementia. This is a question that we get a lot, especially working in acute care in the hospital. We might get a referral, and there's been what we would call an altered mental status. There's been some change from either lack of oxygen or mismanagement of medications or whatever reason. And if we aren't able to immediately get in contact with that the patient's family or the family's doctor and find out that their history, we're often looking at delirium versus dementia. So would you mind spending some time talking about, from a nursing standpoint, what that means to you, delirium versus dementia?
Yeah, definitely. So, really, both of them, like you said, are kind of altered mental states. So, it's someone who's not at their healthy baseline. And the delirium, we can talk about, well, we'll talk about dementia first because that's kind of like what this is all about. So it's like the slower onset, it's irreversible cognitive impairment. Symptoms are constant and consistent, worse on some days, but overall consistent and a steady decline. Delusions are common, but hallucinations are rare. And so the difference in, which is something I didn't really learn until my mental health class in nursing school. So delusions are like a belief, whereas hallucination is like a visual or tactile like experience. And so if there is a person who thinks that their kid was supposed to be home from school an hour ago and they're missing, that's a delusion. As far as they have a belief that isn't true to their current reality. If it is a person who sees a little girl standing in the corner of their hospital room, then that is a hallucination.
Yeah.
And hallucinations are more common in delirium. And so what delirium is it's a more rapid onset of confusion or a change in your level of consciousness. It's caused by a medical condition. It is something that can be reversed as long as the cause is treated. And it gets a little sticky because someone with dementia can also have delirium. So what that would look like would be someone having a day where their systems are or their symptoms are different than what they normally are, or just significantly worse, and not like one day is bad and the next day is better. Like it's just a consistently worse and noticeably worse. A lot of things that can cause the delirium are usually infections. So we think UTIs in the elderly, especially those who are incontinent or have catheters, pneumonia, cellulitis could, if it got bad enough, any change in oxygenation, if you have a patient or a person who is supposed to be on a CPAP at night, and they've decided they didn't want to wear their CPAP, or you've been struggling to get them to wear that for a couple of days, then that can definitely cause it. Anyone who won't stay on their oxygen, lots of different medical conditions. But with delirium, the key is just finding the cause and then treating that. Whereas dementia, I know we'll talk later about some medical treatments for it, but it's not reversible. Like the delirium can be reversed as long as you find the cause and treat that.
So delirium versus dementia, I feel like that's definitely the hardest one as far as when we know there's an underlying dementia, but we have delirium superimposed on top of that. Like you said, I feel like UTIs and other infections are the most common, especially in the elderly, and even in younger adults. I know family members of mine have had delirium with medication changes. It wasn't even the dosage amount, it was just going on a new medication, and they had hallucinations and delirium from that. And it was really scary. But once they figured out what was causing it, it was able to get better, go away. In another interview that I had with an attorney, we talked a little bit about the living wills, and as far as planning for end of life, it's something that we all need to be thinking about and planning for. But I think especially when you get a diagnosis of something like dementia, then you want to start looking at why you still have that window of time, talking about your code status. So whether you want us to do everything possible, or to not push medications, or their feelings about being on a feeding tube or being intubated. So it's something, I've been in care plan meetings where these decisions are thrown at the family very quickly. So I would like to give you a little bit of time for, as a nurse and now a nurse practitioner, what all the code statuses mean to you.
Yes. So a lot of times I feel like people are under the impression that it's kind of like either full code or do not resuscitate. And really there's a entire spectrum of code choices depending upon, whatever the person wants, if they're able to still advocate for themselves, or their power of attorney if they aren't. So everyone knows full code means doing everything until a physician determines that it's no longer going to be helpful. DNR, or do not resuscitate, means pretty much don't code them. And by code, I mean pushing medications, doing compressions, shocking their heart using a defibrillator, or intubating them. However, do not resuscitate does not mean do not treat. So any sort of life-threatening condition that they would encounter up to the point of death would be treated. If they had a UTI, they would get antibiotics. If they had pneumonia, they would get antibiotics. If they had a GI bleed, they would get a colonoscopy, blood transfusions, and possible surgery to fix it. So they will be given everything that is standard of care up until their heart actually stops beating. And that's when measures will be stopped. There are medication only codes, and these are for people who do not want to be intubated. They don't want to have compressions done on themselves. And so what that means is when the heart stops, all you do is give medicines. Don't do compressions, don't intubate. Just if there's an IV, just push meds through the IV. And then there's do not intubate, which is you can push medicines and do compressions, but they don't want to have a ET tube placed because they don't want to be on a ventilator. So do everything, like run a full code, except for not putting down the tube or intubating. And then there's comfort measures.
Yeah, one thing I did want you to clarify with the medication only code in the do not intubate code as far as pushing meds, you mean as far as typically epinephrine, like
Yes,
all these last chance heroic medicine options.
yes.
Yeah. Okay,
Yes,
good.
so epinephrine, which is, an attempt to restart the heart or cause a muscular contraction of the heart. Any other medicine that they would give would be to change a heart rhythm. So all the medicines would be, yes, specifically for trying to restart or get the heart working the way that it's supposed to.
Yeah, good deal. I think as you were talking about, I was thinking, well, how can they take their Tylenol and their Protonics if they're phew, it's very late at night as we're filming. So yes, as far as because I think that would be a much more common code option if people knew that was an option. Because you've got someone in their late 80s or 90s. A lot of people with dementia are underweight in their later stages, and you think about performing an intubation or a chest compression, and that being whether it's your patient or that's your mother or grandmother, that's a very intrusive and potentially painful procedure, and not always something, especially at that age with that diagnosis, that someone's going to come back from. So I actually did not know that medications only was a code that you could run. That's very interesting.
It is. I feel like a lot of patients who I've had who have chosen that, it seems less violent to
Yes.
them
Yeah.
because it's just, like they already have a line or putting a line in like an IV and then just pushing the medicine. It's not like said intrusive or invasive.
Yeah. Okay. So sorry to interrupt. So you were talking about comfort care.
Yes, and lastly, comfort care. So this is the do not resuscitate. Like if their heart stops beating, we're not going to do compressions, we're not going to do medicines, we're not going to intubate. But this is also that the only care they are going to receive is going to be to bring them comfort. So if it's a patient who has high blood pressure, we're not giving them their high blood pressure medicine that day. If they've had strokes in the past, we're not going to give them their blood thinner that day. If we think that if they spike a fever and we think that they have a infection going on somewhere, we're not going to treat them with antibiotics. If we look at their labs and think that they have a GI bleed, possibly, we're not going to do a scope. They're just going to be given medicine to prevent pain and medicine to help with anxiety. There's a little bit of wiggle room here for family and physicians to decide. For example, if a patient has seizures and is on comfort measures, they may still receive anti-seizure meds because seizures can be painful and stressful experiences. And so it would be comforting to that patient to avoid seizures. That's not something that's really curative. It's just something that's going to prevent any further discomfort. So there is wiggle room there. So I see this option a lot for patients who, even if they were restored to their physical health, their quality of life wouldn't be what they or their power of attorney determined acceptable. So, for example, if you have a patient who has decided that they don't want heroic measures done at the end of their life, if their, power of attorney has decided that, hey, their quality of life is really not great at this point, and they get their routine labs done at the doctor and it shows an anemia or a low blood count, and the doctor says, oh, well, we should do a colonoscopy on them to make sure they're not bleeding. I just always want to encourage patients themselves and family members to ask, what are we going to do with the information that we gain from this? Because if the answer is nothing, it's important to keep in mind how traumatizing some of these procedures can be to patients, especially those with advanced dementia who don't understand what's going on. And so if we're not going to treat a colon cancer mass if we find it, why are we going to find it? So I think a lot of people don't question physicians or nurse practitioners because they feel like, oh, they're the doctor, they know what's best. But I just want to empower people to really ask questions like, okay, what's going to be gained from this? And if we do find what you think we're going to find, what are we going to do at that point? And if the answer is nothing, then definitely comfort measures may be a fitting option, because that's not like I feel like people worry about comfort measures as well, they're just gonna, just let me die. And it's not a just kind of push them to the side and let them languish. It's a let's make them as comfortable as we can, because even if we fix this UTI, even if we cure this pneumonia, we're restoring them back to a quality of life that they would not find acceptable.
Yeah. Oh my gosh, you're touching all my heartstrings. I know we've had many conversations about, we could do an entire series on comfort measures alone, as far as bringing quality and dignity to the end of a person's time on earth, whether they have dementia or not. So maybe that's something we can look forward to in the future, because I know that's something we're both very passionate about. In the interview with the attorney, he also talked about, when you're looking at your will and your living will, specifically your guardianship, your power of attorney, to really don't be afraid to ask questions to your
Mhm.
doctor. You and I both work in healthcare. I know, and I kind of try and tell my patients, I know I talk fast. I know I'm giving a lot of information. Stop me. Like, stop me if I'm not making sense, or if you have a question about anything. So the attorney really encouraged everyone to, when they're making that plan for what they'd like at the end of their life, or they're trying to think, for mom, dad, grandma, grandpa, what are going to be the ramifications of the choices that we're deciding now, and to not be
Mhm.
afraid to consult with a medical professional like yourself. What are the long-term effects of being on a feeding tube? What is it like to be intubated and or extubated? Those are, I think, and it's tough information to hear sometimes, but I would so much rather encourage people to be informed, to have those conversations, because we just see it so much that they don't want to feel like we're just, if someone goes on comfort measures, that we're just denying them care. We're just not going
Exactly.
to be paying them any attention, um, when really comfort measures can bring so much relief and peace to a lot of our
Mhm.
patients. But again, I know that's something you and I could talk about for so long. So we will save that for another episode.
Well, one other thing I would like to say while we're talking about consulting with physicians is that if physicians give you this if the options that they present you aren't options that you're comfortable with and you don't think your family member would be comfortable with, like, push back, ask more questions. I've heard a physician at bedside one time tell a patient to get a feeding tube or starve, and I'm like, that those are not her two options. Like,
Yeah,
that's not that's not good enough. Like, we have more options for people available. And so if you're presented with a lose-lose kind of situation for yourself or a family member, like, definitely ask questions, um, to bring about like another option that would be more fitting, because there are better options out there. Some physicians may just not be familiar with them, or maybe aren't taking the time up front that they necessarily should with patients. So if you get an answer that you don't like, definitely continue to ask those questions.
absolutely. Absolutely. And as the swallowing specialist in the hospital, as the speech pathologist, I can say more times than I can count, the conversation has been, oh, well, your options are, if you don't want mama to starve, we have to put in this feeding tube. And so, there's so much to be said about, how our body processes hunger and how our body isn't really able to use nourishment in a lot of ways in the last days of life. And, such a complicated thing. Or even worse, if you don't start eating, we're going to have to put in a feeding tube. That's one thing that just, oh my gosh, takes my breath away. So yeah, so definitely agree with you there. If you are presented with a lose-lose situation, keep pushing, ask for second opinions, especially, and if you're in a big hospital, you don't have to talk just to their primary caregiver. You can get other consults throughout the way. So good deal. So our last topic tonight, I believe, is going to be about medications. I think I see a lot of, I'm involved in a lot of support groups online, and even just working in the healthcare setting, people say, well, we haven't got a diagnosis of dementia because there's no treatment. There's no treatments out there. And I understand what they mean, in that it is a progressive disease process. It is something that is going to get worse with time if it's a true dementia. So kind of thinking of three things. There's the treatment of symptoms. So there's things we can do to treat reduced attention and reduce memory, thinking like using notebooks and timers and environmental modifications. There's treatment of behavioral systems, so ways to help keep the patient safe and the family, the caregivers, comfortable and safe. And then therapeutic intervention. So that is going to be like what I do in speech pathology, occupational therapy, physical therapy, psychology. Those are all therapeutic interventions. So for now, Kayla, I would like for you to give us a little bit more information regarding certain considerations for medication management.
Okay, for sure. So a lot of dementias will be diagnosed and treated by a neurologist. Rarely will at least the primary care physicians in our area that I've worked with actually want to manage the medications used to treat dementia. But some good things to know is kind of like if you have someone with dementia, what are some medicines you can and can't give them over the counter. So one thing, or two different types of meds. One are allergy medicines. So any antihistamine, that's like Benadryl, Zyrtec, Claritin, Xyzal, anything that's for seasonal allergies, that can cause increased confusion. It can cause urinary retention, which can be bad as far as leading to incontinence, and it can also cause constipation. So those are all available over the counter. Definitely all things you'd want to discuss with a physician before taking or giving to someone with dementia. Oxytrol is relatively recently made over the counter. It's a medicine to prevent urinary incontinence, but its side effects also include the increased confusion.
So interesting. I didn't know that. We talk about, as far as swallowing disorders, there's some over-the-counter medications related to allergies that can either dry you out or, mismanage saliva production, but I didn't know that.
Yeah, and that's probably those ones.
Yeah.
Another thing I see a lot of people struggle with is like insomnia or messed up sleep schedules. And so, of course, Benadryl is one that we just talked about not wanting to take. Melatonin, of course, everything needs to be checked with a physician, but melatonin is something that's generally very safe, low medication interaction, and something that family members could ask physicians about trying over the counter for sleep. Sleep schedules are very important. Good sleep hygiene, which means having your routine in place, making sure it's nice and dark, unless there's a fall risk, and then that it's, not too dark. maybe some music, something, anything that they would enjoy that helps them like relax, wind down, kind of mental, like environmental cues that it's time to sleep. Um, Another thing is caffeine. So caffeine, especially not isn't dementia specific, but in the elderly, caffeine takes a lot longer to process out. So you don't want to have a cup of coffee with dinner unless it's decaf. All caffeine consumption should be stopped by noon, at latest 2 p.m. In order to kind of get it all out of the system in order to sleep well at night. And then lastly, this isn't about medication specifically, but taking medications. It is usually pre-advanced before patients resist taking medications, but that is always something that's really difficult, I think, not only for healthcare workers, but especially family members to deal with, because family members are trying to do everything right for the patient, trying to get them what they need for them to be healthy, and the patient's just not in a mood where they want to take medications anymore. And so some ideas, I would definitely talk to providers about cutting down on their medicine list. Like, is there anything here that we can cut out? Like, can we start backing down on their blood pressure medicine? If they're on 3 and being on 2 isn't going to kill them, like if they're well enough controlled, can we back off one of their diabetes medicines if their blood sugar isn't dangerous? Start looking at trying to cut those down, or going from taking something twice a day to maybe getting an extended release medicine version that they could take just once a day. And I think, and I know we talked about this earlier with as far as why are we doing this, but there comes a point when I think you have to ask, like, why are we trying to keep their heart in rhythm? Why are we trying to keep their blood pressure in check? Why are we trying to make sure? And it's definitely a personal decision. That's not something that anyone can judge for, because a lot of these medicines are going to potentially prevent further suffering, as well as prolong life. So it's definitely a personal decision for how hard do we want to work to make sure these medications are still taken on a daily basis, versus are we okay with what might happen if we don't push these medicines being taken?
Yeah, that kind of goes back to the comfort care, as far as thinking about, if you have so much time left with that loved one. And again, like you said, it's very much a personal decision, going off one medication can have severely different repercussions compared to going off a different medication. So it's very important to look at that. But I know at the nursing home, I had patients that just hated taking medication, especially ones sometimes in the middle to late stages of dementia, that didn't know where they were, why they were there, didn't want us coming into their room. Just if you have so few opportunities to have a good interaction with your loved one, and then you can kind of hurt that trust in a way by then trying to force medications on a person. So yeah, I think that's very important. And again, that's when you want to talk to your doctor about what are the repercussions for this medication list. What's going to happen? What are our options? Realistically, what are we looking at?
Honestly, I'm not really sure 100% about the pricing of dementia-specific medications, but I know that a lot of other medications are super expensive. And I don't think that there are a lot of hard decisions to make when it comes to taking care of someone with dementia, and financial expense should not play a role. Unfortunately, it does in our world and in our day and age. But there's a app or website, and it's just Good RX, and you can go on there, type in whatever medication it is that the doctor's prescribed, and they will give you like a cash price that you can take to the pharmacy. And a lot of times it's cheaper than even using insurance. So that's one option for people that I found not a whole lot of people know about. Some medications, especially insulins, and then inhalers for patients with lung issues, are super expensive, even cash price. So there are drug reps who go around to every physician office, and they give samples, and all they want is for that physician to prescribe their medicine. And in order to get that medicine into the hands of more people, they usually have a lot of good programs that help with the financial aspect of it. So if your physician mentions like, hey, there's this new medicine I'd like them to try, or you're having trouble getting one of their medicines covered, I would just ask the physician and be like, hey, next time the drug rep comes around, like, could you give them my information, or can you give me their information? Do they have any programs that you know of that could help us pay for this? Because a lot of time the sales reps are really good resources for getting medicines covered for patients. They know the best ways to get their medicine into someone who needs its hands, so they're a good resource.
That is really interesting. I've heard of the GoodRx app. I think I've even used it a time or two, but as far as contacting a drug rep, that is very creative. Very interesting. Since you have worked in so many different locations and with so many different populations and had so many different roles, do you feel like there's kind of a few things or one main area that a lot of caregivers struggle with understanding about dementia, or maybe that healthcare providers don't understand well about dementia?
I'm not sure if it's a misunderstanding or just a buildup of frustration over time, which I understand with caregivers. With providers, there's really not an excuse for that behavior at any point. But a lot of people, I feel like, just assume that I've heard a lot of patients with dementia called stubborn. They just don't want to work with us, or he's just got an attitude today, and that is not the case at all. Like you wouldn't say someone with high blood pressure, well, he just didn't turn his heart on the correct way today.
Yeah.
Like, we don't blame physical symptoms on patients' attitudes, and we can't blame behaviors on the person with dementia, which is very easy to say as someone who does not live with someone with dementia, and is not in that caregiver role 24/7. I think that definitely family support groups and therapy, any kind of resource as far as getting help and connecting to people who understand that role as well, is very important. But I think it's not that the person is changing, it's more that their brain is changing, and that's very hard to accept and hard to wrap your mind around. But I think that hopefully, caregivers and healthcare workers as well could find a little bit of peace in that it's not the changes aren't occurring, it's not the person, it's just their brain.
Yeah. And I think there's some, with the help of we both are very big on self-care for the caregivers. That's another interview I have coming up with a mental health counselor, is talking about, as a caregiver, making sure that you're taking care of yourself. But I think there's a lot of peace to be found um, for the caregivers and being able to understand about why we're seeing these changes in our loved ones with
Mhm.
dementia. That's the whole reason I did created my Dementia 101 course, is because I had so many families that was just the persistent question. As the medical professional, I'm thinking, what questions do you have about your medications and your therapeutic interventions? And they're just like, why? Like, why is this happening to my dad? Why is this happening to my grandma? And so trying to take the compassion that you need in the real world and then matching it with um, looking at the medical model of, okay, if it's a frontotemporal dementia, those areas of the brain work with language and being able to make good judgment calls, being able to reason. And so that's why your dad with this form of dementia is having these difficulties. And so I think with having that good understanding of dementia, you don't have to get your master's, you don't have to become a nurse practitioner, but I think with having some basic understanding of, your brain is not able to talk to itself very well, and
Mhm.
that's why you're seeing those changes.
Mhm.
And I think a lot of it that comes from medical professionals, like you said, it's inexcusable. But I hear that sometimes as well of, oh, they just didn't want to work with us. They're in a mood, they just don't want to get better. And there's really no excuse there. If you're working with these individuals, you need to be informed, and um, it is better. It is more, it's more work if you say, okay, their dementia is just like their blood pressure. They can't help it.
Mhm.
We need to be the ones to help manage it. We need to be the ones that go in with a calm attitude, that explain who we are and what we're doing, and don't mind repeating ourselves, and don't mind taking you to the bathroom for the 10th time today or whatever. If we as healthcare providers really focus on treating it like what it is, a medical condition, um, you know, and then we're able to offer better education and better support for those family members and caregivers as well. Yeah. Well, good deal,
Yeah.
Kalis. Thank you so much for giving us your time and your research. And I have a feeling we'll be interviewing you again very soon. Thank you so much.
Thank you. Thank you. I appreciate it.